So good morning. This is my disclosure. Left atrial appendage occlusion is an effective alternative to oral anticoagulation in non-valvular AF patients. While the left atrial appendage varies significantly in size, morphology, spatial orientation, which makes this especially challenging for percutaneous occlusion. In the clinical practice, occluder insertion is guided by TE. Multi-detector CT provides 3D datasets allowing accurate imaging, and 3D printing has been used anecdotally in the literature, especially in the context of congenital structural heart disease. So our objective was to evaluate the ability of printed 3D LAA models based on MDCT datasets to predict left atrial appendage occluder size. We included patients planned for LAA occluder insertion who underwent MDCT prior to the implantation. We used a 256 slice scanner by Philips with retrospective gating, and you can see here the scan parameters. CT images were loaded onto IntelliSpace portal to create a model-based segmentation, and the segmentation was edited to properly include the left atrial appendage, the left superior pulmonary vein, and the adjacent left atrium. And the original tissue was subtracted from the expanded outer layer in order to create a left atrial appendage outer layer only. Then the outer layer of the left atrial appendage tissue was saved as an STL file, which is a standard format for 3D printing, and 3D models were printed using a semi-solid material. And here you can see examples of oops, no, not what I wanted to do. Okay. Of our models, and you can see here, this is the outer surface. Okay, so this is the outer surface of the 3D model. You can see here the left superior pulmonary vein, the left inferior pulmonary vein, and left atrial appendage. And this is a view that we're used to when we're looking at the 3D volumes created using the CT. Here you can see what we actually created, which was a hollowed model of the left atrial appendage. Of course, we cut it in the middle so we can actually access it. And we can see here that this is the orifice of the left superior pulmonary vein, and this is the orifice of the left atrial appendage. 3 cardiologists who were informed which type of occluder was inserted used the STL models to predict the device size by fitting different devices into the STL model. And the chosen device was compared with the actual device implanted during the procedure. So our cohort included 29 patients referred for LA occluder insertion and who underwent CT with an average age of 78. 64% of them were males. Watchman devices were inserted in 17 patients, and ambulatory plug devices were inserted in 12 patients, while 2 procedures have failed with the insertion of no device. Now, this is a rather busy table, but let me just walk you through it. So here you can see the device type, with the upper part being the Watchman device, these are being the ambulatory device. This is the actual device size which was inserted during the procedure, and these are all 3 physicians who have identified the different device sizes that they want to use when they use the STL. So you can see that these are 2 procedures that have failed, that all 3 physicians have actually predicted that these will fail. In regards to the Watchman devices, there was low agreement between the predicted device size and the STL, and using the STL model and the inserted device size, with a Lin concordance coefficient of 0.315. However, when looking at the ambulatory plug device, there was very high correlation using the STL models and the inserted device size, and the actually inserted device with a Lin concordance coefficient of 0.778. When comparing the 3 physicians, there was a good agreement between all 3 physicians looking at the Watchman devices with an average intra-class correlation of 0.816, and an excellent agreement between all 3 physicians with an average intra-class correlation of 0.915 when comparing all 3 physicians. So let's take a look at what we actually did. This is volume rendered. Oops, no. Okay. This is volume rendering of the left atrium. Here you can see the left superior pulmonary vein. This is the left atrial appendage sticking here on the side. And this is actually the model that we have created, the hollowed model. You can see that we have thickened it on the outer surface because we needed to actually print a model, and the wall of the left atrium, the left atrial appendage is very, very thin. However, we made sure that we're actually the details, the actual details from the CT data of the inner part are totally relevant. As we look here, we can see here that this is the orifice of the left superior pulmonary vein, and this is the orifice of the left atrial appendage. We can see that with the printed model as well. This is the surface of the mitral valve, and again, orifice of the left atrium and orifice of the left superior pulmonary veins with the veins sticking here on the side. And you can see here how the Watchman device was inserted into the model. This is a different case where an Amplatzer device was inserted. So again, an outer surface volume rendering with the left superior pulmonary vein and the left atrial appendage. And as we look from the inside part of this hollowed model, we can see the left superior pulmonary vein orifice and the orifice of the left atrial appendage. Again, with the printed model, the orifice of the left superior pulmonary vein and the orifice of the left atrial appendage with an Amplatzer device in place. The study has several limitations. It was a retrospective study, and it looked at 2 different devices. And the printed model, although we used flexible material, of course, it's not similar to the human tissue, and this is going to be an inherent problem whenever we look at 3D printing. And just to conclude, LA printed STL models were accurate in predicting both procedural failure and device size for the Amplatzer Clive devices, and no such correlation was demonstrated for predicting Watchman device size. Structural heart disease, along with targeted procedures, is becoming central in cardiology procedures. And different anatomical structures are at the current focus of these procedures, including the aortic valve, the mitral valve, and the left atrial appendage. And currently we're using MDCT data sets only for visual guidance and planning procedures. And I think we can really might consider going to the next step. So utilizing this data from CT in personal tailoring of per patient devices when we use the CT data. And considering using STL models of different anatomic structures could further help procedure planning, especially when the anatomic structure is complex and unique to each patient, as we see in the left atrial appendage. And of course, further studies are required in order to evaluate the potential role of printed such models in the assisting LL occluder procedures.